It is my sincere pleasure to participate in the 2025 Summit for the Anal Cancer Foundation for locally advanced anal carcinoma regarding ASCO guidelines that were recently created in the past year. My name is Dr. Cathy Eng, and I'm at Vanderbilt Ingram Cancer Center. Here are my disclosures. I apologize for the delay. I am traveling, and I am at ESMO in a hotel room, so please excuse the quality of the taping. I believe most of this has already been discussed prior to this session, but a kind reminder that the incidence of anal carcinoma continues to rise annually. The 5-year survival is expected to be about 71%, and the majority of patients will present with early stage disease, meaning that it has not metastasized. And the good news about anal carcinoma, we're going to be focused specifically on squamous cell carcinoma, is that it is a curable cancer, but it is very important that patients receive appropriate therapy. As you can see here on the right, the majority of patients will present, 77% of patients will present with local disease or regional disease, which may involve the lymph nodes. And the 5-year survival is very good for early stage disease, anywhere from 85% if there's no lymph node involvement to 70% if there is lymph node involvement. But there are certain prognostic factors that we will discuss as well. So what is the standard of care approach for these patients? Once again, we're going to be focusing specifically on squamous cell carcinoma of the anal canal. Anal adenocarcinoma and carcinoid tumors are separate entities that require different therapies. Combined chemoradiation therapy is the standard of care for early stage squamous cell carcinoma. The dose of chemotherapy is meant to only enhance the radiation treatment for optimal benefit. We now know that 2 chemotherapeutic drugs are better than 1, but there are certain exceptions in which we would consider only 1 as a therapeutic option. And sometimes when we're even providing 2, we might choose an alternative such as cisplatin for mitomycin in the setting of a transplant patient or an HIV positive patient or other immunocompromised state in which their immune system is not 100%. At the end of the day, radiation is the key to cure here. Any residual disease or recurrent disease after chemoradiation therapy is complete must be surgically resected for complete cure. And that is usually with the loss of the anal sphincter, resulting in an APR or abdominal perineal resection. Now, what are the potential toxicities of therapy? We talk a lot about the treatment being curative. It is for a short duration of therapy. It's roughly about 5 weeks, Monday through Friday. That those 5 weeks can be rather challenging for patients due to fatigue and other toxicities. So I show you here some of the drugs we use. So 5-FU is the base of the treatment. It is provided intravenously in this case, and we'll talk about capecitabine as an alternative later. It may result in hand-foot syndrome, diarrhea, mouth sores, and remote risk of cardiac vasospasm. Mitomycin C is the standard of care across globally. However, it can cause significant reduction in your blood counts. It can cause significant radiation dermatitis, mouth sores, fatigue, because the counts are so low, and in rare instances cause myelodysplasia or a pre-leukemic state. Cisplatin is an alternative to mitomycin. It also has different toxicities, but it does have toxicities. It may cause ringing of the ears. A lot of this is cumulative, meaning depending upon how much you receive. It can cause peripheral neuropathy. It can cause damage to the kidneys, and it can cause a change in your palate. So some of the foods may actually taste metal-like while you're trying to digest your food. And obviously, this may potentially impact your diet negatively. Now, these are the 2 classic trials regarding curative treatment for early stage disease. One of these is RTOG 9811. Why is this important? Well, it took the standard of care regimen and decided to look at the role of providing chemotherapy prior to chemoradiation therapy. This is what we call induction treatment. And then also, not only did they do that, but they also decided to look at a different drug other than mitomycin. They decided to look at cisplatin in this setting, and that was based upon some promising phase 2 data. So this is a big phase 3 trial. Originally, it was supposed to be over 900 patients. It was reduced down to a little less than 700 patients. And basically, what this trial noted is originally, at the end of the day, it noted that the role for induction therapy was not beneficial in these patients. And it appeared to be that there was less uh, uh, less colostomies in the mitomycin arm versus the cisplatin arm, and in part, it may be because that delay due to the induction therapy. Um, and this is some of these findings. Um, at the end of the day, they were unable to determine superiority of cisplatin versus mitomycin. There was really no difference statistically in regards to overall survival for this patient population. The Act 2 trial decided to look at a different aspect. So here, I do want to point out the dose of mitomycin is 10 milligrams per meter squared given on the first week and the last week of radiation treatment. You go to Act 2, they gave a dose of mitomycin at 12 milligrams per meter squared with the 5-FU, and they compared a head-to-head comparison of cisplatin in combination with 5-FU. But they also did a second randomization, which I do not show here. This is the largest phase 3 trial to date, where after the completion of chemoradiation therapy, they looked at the role of adjuvant. So 2 cycles of adjuvant chemotherapy with 5-FU cisplatin, so post-radiation treatment, to see if that improved disease-free survival and overall survival. And basically, at the end of the day, that did not demonstrate any benefit. So RTOG did not demonstrate any benefit for induction. Act 2 did not demonstrate any benefit for adjuvant chemotherapy or post-treatment chemotherapy. The best thing about the Act 2 trial, though, is they looked at what would happen if you would delay evaluating the patient radiographically and with an basically a proctoscopy or a flexible sigmoidoscopy to evaluate the primary tumor. And they noted basically if you waited up to a 6-month interval after the completion of chemoradiation therapy, it actually would benefit the patient and allows them a greater chance of sphincter preservation. So you're less likely to end up with a colostomy. Prior to Act 2, basically, the surgeons would evaluate the patients very early on, within 2 months or so to 3 months following the completion of chemoradiation therapy. And if there was any residual tumor, they used to take the patients directly to surgery for a permanent colostomy. Act 2 basically noted that if you just watch the patient conservatively, as long as you notice shrinkage or some stability, and then gave the patient more time to recover, you have up until 6 months after the completion of chemoradiation therapy to make that decision whether or not a permanent colostomy is needed. So in this trial, this once again the largest trial to date, true head-to-head comparison for the first part of this trial, there was no difference, as you can see here, in regards to complete response, partial response, and in regards to local regional disease, basically it was not statistically different. What is noted is that basically that the point of the trial, though, was to demonstrate superiority of cisplatin, and that was the point of both of these large phase 2 trials. And as a result, because both trials did not demonstrate superiority for cisplatin, as a result, mitomycin is still considered the standard of care. But they also noted in this trial there's a negative impact in regards to delays in radiation treatment, that it negatively impacts overall outcomes. And so that's extremely important for patients. So here you can see at this diagram here, if patients had received treatment that were longer than the original a number of days allotted for the completion of chemoradiation therapy, it negatively impacted this red line here, the overall outcome of the patient. So we never try to delay any radiation treatment. Obviously, 1 day is okay or 2 days is okay due to a holiday or if the machine is down. But if anything, we would rather hold back from the chemotherapy and allow you to proceed with radiation treatment to optimize your overall outcome. And here, basically, you note that those patients that have a complete CR or complete clinical response, these are the ones that did not fare better in regards to improved progression-free survival. And once again, you can see that it continues over time if you just give the patient more time as well in regards to assessment. So the progression-free survival is extremely important, and a complete response is required if you want to preserve your sphincter. So what are some prognostic factors for cure when you're considering chemoradiation therapy? Obviously, there's some acute and chronic radiation toxicities, but risk factors for recurrent or persistent disease include those that are tumors greater than 4 centimeters, lymph node positivity, and once again, failure to complete chemoradiation therapy. So this is kind of the framework from what we work with. If there's any hint of residual disease, the patient is recommended to go for a permanent colostomy through an APR. So what are the key questions of the ASCO guideline? Well, what is the recommended radiosensitizing doublet or single chemotherapy agents for stage 1 through 3? What is the recommended dose and schedule? And is there a role for induction chemotherapy? And is there a role for adjuvant chemotherapy? And here we'll be discussing this. So, in regards to the treatment, 5-FU-mitomycin, as stated earlier, is the standard of care. Superiority of cisplatin could not be identified, and as a result, mitomycin remains the standard of care. However, there are some cases where you don't want to have a significant reduction in blood counts, and that is one of the main side effects of mitomycin. So we sometimes substitute cisplatin for mitomycin. And in regards to the use of oral 5-FU or capecitabine, it could be considered as a substitution for IV 5-FU, but once again, there is no prospective data to say that they are equivalent. There's only retrospective data. So there's not a lot of hardcore evidence for the use of oral capecitabine, but we do support it based upon large retrospective data. In regards, what is the optimal dose and schedule? If you look at the original trials, once again, 5-FU is the standard of care for both of the bigger, these two big phase 3 trials. RTOG 9811 gave a dose of 10 milligrams per meter squared on the first and the last week of treatment, but this resulted in 61% of patients having significant drop in their blood counts. Act 2 only gave one single dose at week 1, but it was a higher dose of 12 milligrams per meter squared, and this resulted in some toxicities impacting blood counts, but in only 25% of patients. In regards to treatment breaks, RTOG had more treatment breaks, 58% versus 26%, which is quite a bit of patients, and that could obviously impact the overall outcome of the study. And furthermore, only 50% of patients actually completed their treatment as planned, and 38% of patients never received that second dose of mitomycin due to their blood counts. Is induction chemotherapy recommended for patients? So induction meaning before treatment. So prior to radiation therapy or prior to surgery. Does it help improve overall outcomes by providing chemotherapy before chemoradiation therapy? And the answer is no. We have two large phase 3 trials, RTOG 9811 and ACCORD-03, which I show here very briefly, where they looked at the role of induction chemotherapy prior to combined chemoradiation therapy. And basically, there was no difference in the colostomy-free survival. So we don't recommend it. What about the role of adjuvant chemotherapy, which is post-operative treatment, or in this case, post-radiation treatment? There is no role for post-radiation therapy chemotherapy. ACT2 demonstrated there was no difference in disease-free survival. Now, we do have one trial pending called EA-2165 that is looking at the role of adjuvant chemotherapy with 6 months of immunotherapy in regards to disease-free survival. That trial has completed enrollment, and we are waiting for those results. Here's the guideline, basically reiterating what I'd mentioned earlier. So you have basically here mitomycin based upon the RTOG 9811 with a dose of mitomycin on days 1 and on week 1 and week 5. However, this once again can result in significant impact on your blood counts, and the majority of patients, actually not 50% of patients, as mentioned earlier, did not complete their recommended treatment, and 38% never received that second dose. Here, if you want to substitute capecitabine, you can. And here is the consideration of using cisplatin if you do not want to use mitomycin. Once again, I would consider cisplatin in the setting of an organ transplant patient, such as a cardiac transplant patient. Would not consider in a kidney transplant patient because obviously you don't want to negatively impact the kidneys. In that case, I would just use single agent 5-FU. Also in patients with very low CD4 counts, cisplatin would be my preferred regimen versus mitomycin C. And once again, in patients with poor performance status, meaning their energy level is not up to par and it is questionable, then I would consider just doing single agent 5-FU as well. So here's my contact information. Thank you so much for your time and attention. And I'm very grateful to the Anal Cancer Foundation once again for bringing awareness regarding anal carcinoma and supporting the symposium and having all these lovely individuals participate in this symposium to increase awareness and improve overall outcomes. So I wish you well, and thank you once again for taking the time to listen to this lecture. Have a great day.